Welcome, EGP learners, to our stream that we've got today. We're going to be talking about the PCN DES and particularly the contract specifications that came out about 2 weeks ago. And I'm sure many of you have had the real opportunity to go through these documents in absolute detail. But if you haven't, well, we're just going to go through it for you and explain kind of the key points that you probably need to be aware of from mine and from Andy's perspective as clinical directors, and show you the document as well so you can figure out the points you definitely need to zero in on. It's an interesting document, isn't it, Andy?
Yeah, it's interesting. So 104 pages. I think these videos are really helpful for people, because for me, the hardest part about dealing with a document that's 104 pages is looking at it for the first time and just sort of understanding the shape and where you should be looking in it to find what you need to know. So I think even if people don't pick up on all the details when we go through this walkthrough, and I know we won't be picking up on all the details ourselves, it just makes the whole thing less daunting. You know what the document looks like, and you're better able to go in and get what you need from the document going forward. So I think these are really helpful, and I'm excited to dive in.
Absolutely. And just for clarity, so there are a variety of different documents that came out all at the same time. We're talking about the main contract specification that we're going to be going through today, and that's the 104-page document. We'll put the links to that in the show notes once we've finished. I'm afraid they're not right there right now, but we will put them in, as well as a couple of other links that we're going to cover throughout the talk. And then following this, in the next couple of weeks or so, Andy and myself are going to be going for a deep dive into each of the individual sections themselves. I'll be uploading those over the next couple of weeks to the EGP Learning channel as well. So definitely check out those, and we will cover those in more detail. We'll talk about them in a second. But let's bring up the actual document itself, so we've got something to talk from. And this is mainly so that you are aware what we're talking about. Do you want to start us off, Andy?
Yeah, so I think the best way to tackle this, Gandhi, is if we scroll through, we've already sort of been through it together and put some notes on. So we'll scroll through, talk through the headings, what's generally in each section, and where we think there was something that was different from the previous iteration of this document from last year, which was very similar, actually. There's not an enormous change from one year to the next. We'll pause and have a think about it. And I know we've got people watching, haven't we, Gandhi? So how do people get their questions to us and possibly to the Q&A section afterwards?
So absolutely, if you do have a question, as I put in the chat already, just pop it into the chat and we will go through it throughout. We'll probably go down in sections, so do wait till we get to a particular section, stick a question in, and then we'll come back to those. If not, we'll cover everything towards the end. And don't feel that you can't ask a question. It is a massive document, so we will try our best to cover it. And as an extra special favour that we have had from NHS England, although they couldn't join us today, and we did invite them across today, but it's a Saturday, and it's, fair enough, hats off to them that they're busy and things. What they have said is that any particular questions that we can't help you answer, and there's probably going to be a couple, they're more than happy to try and answer afterwards, and they'll put those response to us, and we'll stick that in the show notes. And so definitely check back for that afterwards as well. But let's get cracking with the document itself. Whilst Andy's scrolling down, I'm going to stick it in the link to this in the chat as well, so that people who are joining us live can follow through on the actual document as well if they want to.
Good. So yeah, so just scrolling through, and we'll just sort of pause at each of the blue headings. So it's fine. So there's a lot of a trip down memory lane about the introduction of primary care networks in the introduction. As with a lot of these legal documents we're all becoming more familiar with, they define what the different entities and things are, which are described later within the document. It's really something to refer back to, I think, if you're wondering what it means by something. Talks about the relationship between our main PMS and GMS contracts, and essentially when you opt in, it's a modification of your GMS contract, isn't it, Gandhi, which is important for people to understand that it becomes part of your core contract until you opt out. So that's quite significant. But I think most people are opted in at this stage. Most practices are members of primary care network up and down the country, I think, with a few exceptions. Section 4, basically sections 1 through 6 essentially describe the kind of legal creation and maintenance of primary care networks, and there's not a great deal that is different or that is really relevant to the day-to-day running of a primary care network. And these sections are really helpful to refer to if, say, a practice wants to leave, if a practice needs to leave, if you need to change the lead practice for funding purposes, and all of these sorts of provisions are stated within these sections. We just made a note at section 431 one, just in case people are worrying if they need to do something moving into the next year. Do we need to sign another agreement? Do we need to get the practice to do something? So the answer to this is no. It's automatic re-enrollment. If nothing's changed, then it just rolls into the next year. So just being clear about that. So
although one thing I probably would add with that, it is probably worth just reviewing your schedules at least on an annual basis to make sure they're all appropriate and correct, and there's not been any changes that you haven't quite been aware of. I mean, obviously the past year has been unbelievably busy, and there may have been changes that just need a little bit of tightening, particularly things like the data sharing agreements and that kind of stuff, particularly with all the new tech many practices are using. Just being aware of that and new system changes. Yeah, it is probably worth just doing that exercise of reviewing the documents, but by no means you don't have to do anything actively to maintain being part of the PCNs and that kind of stuff.
Yeah, that's really true. So the data sharing is part of these. It is somewhere within this. I think it might be in section 4, but within sections 1 to 6. Yeah, that's the area that might have changed or advanced or just marched forwards. A lot more than people expected over last year. So yeah, it's important to make sure that's in place. And I know, we always work with information governance in mind, but in pandemic times, sometimes that's felt like less of a priority, and we've done things because they needed to be done. But now's probably the time to reflect and start tightening those things up. So we'll get through section 6 in a second. So section 5.3, we just made a note on, hadn't we, Gandhi? Just to remind people, really, because we're 2 years-ish into the primary care network project, and clinical directors have been in post. Some will have changed their clinical directors, and actually in Nottingham, one of our PCNs is in the process of refreshing and changing its clinical director at the moment. But it's just a reminder that the DES states that the PCN clinical director should be rotated on a reasonable term. So there should be some process for refreshing the clinical director. I think we thought about this when we were doing our schedules, and I think we have a term of three years, then reselection, re-election. So I think we'll have to look at that in a year's time. Anything else to say about that, Gandhi?
Yeah, and I guess the more in-depth DES document does point out how you might want to go about re-electing, a clinical director, or whether it's just by assent, or whether it's a direct vote, or other kind of mechanisms. And like you say, Andy, it doesn't actually specify what a reasonable term is. That could be whatever I think that the network feels it to be. You could potentially have that on an annual basis, but I would say that's going to make the role really difficult to maintain. Similar to yourself, I think we put 3 years in as an initial term, with a view to extending it if there was mutual assent by the member practices and stuff from there. So yeah, it'd be interesting to see how networks progress with their clinical director roles in particular, because there has been a lot of challenges, particularly over the past year, and how that's going to manifest it for networks and things will be interesting, I think, to see.
Yeah, I'd love to hear in the comments if anybody's got quick fingers, just if they're aware of clinical directors changing much. I know some people had resigned for various reasons. Just be interested to know what the churn is or not, because it's a pretty challenging role, actually. Lots going on, lots to do. And then just reminding us that if you change the clinical director, you need to inform the commissioners about that. So
I think we'll see how that progresses with the clinical directors now having a potentially larger role in things like ICSs and that kind of stuff as well, as part of the new direction that's come through from the white paper in particular, and when or if that gets assent, I think that's going to have an interesting impact in the way that clinical directors are used and have their role. So that'll be definitely one to watch.
Yeah, just scrolling through a few sections, just talking about what happens if practices merge, split, need to leave. So just indicating the content of this section really, and where you can find, and that if things like that are happening within your network, this is where you can find some guidance about what to do. I can tell my scrolling finger is going to be very tired by the end of this 3-page document.
There we go.
So here we are, section 7. So we got there. So this is where I think the meat and bones of what people really are probably going to be interested in from, for sort of day-to-day running and moving their primary care networks forwards. So off we go. Additional roles reimbursement scheme. So made a note for us to go to the table here, Gandhi. Shall I scroll down there? Or we?
Yeah, I think so. So, as many people are probably aware, one of the main thrusts of the PCN DES contracts is the provision for the finances for the additional roles. And we had initial roles that started off in year one, which was focused around the clinical pharmacists and social link workers. And then year two expanded that to a total of, I think it was 8 roles in total. And then this year was the startup of 2 of the additional roles that were definitely planned from the start, but then they've also added some extra ones as well this year. So this year, the paramedics and the mental health workers came online, although in part, and we'll come to that in a second. But then in addition, they've also added, I think it's 3 additional ones. So it's the training nurse associates, the nursing associates, and the advanced practitioner roles, which have been the 3 new ones that have been added in just this year. And what's been interesting is obviously how they're going to be potentially used. And there have been a couple of interesting adjustments, shall we say, to how they can be accessed as well. I think the big one, I mean, shall we talk about it now? That's the mental health workers, isn't it, Andy?
Yeah, let's go deep on that now. So so the mental health practitioners. So I think both of our PCNs were probably really interested in this. Probably all PCNs, given the amount of work in general practice which is related to those mental health cases that sort of fall between primary and secondary care. So there was a lot of there was and there is a lot of hope for this role in terms of improving the care for those patients, and the impact that they can have on the workload practices. So the big change here is that rather than being 100% reimbursed to the primary care network to fund the payment of that individual, it's now 50% reimbursed, with 50% coming via a suitable organisation, most likely the local mental health trust, or I think that would be the case in our area. So that's quite a big change.
Yep.
How did you receive that change, Gandhi?
So I think there's pros and cons with this, isn't there? So the pro is that you've got the joint funding responsibility from the network and from the local mental health trust. And I think my understanding of this, and obviously this is just my guess, the reason this was brought in was to try and not destabilize the local mental health trust in terms of networks just pulling out all of the mental health workers and that kind of stuff into PCNs, and then leaving the mental health services with nothing to do. But then the other part that was, I guess, the negative is the limit of the number of people that you can have. So in this financial year, 21 to 22, you can only have 1 whole-time equivalent mental health worker for a PCN up to 99,000 patients. Over that, you can have another one. And then next year it goes to 2 whole-time equivalents, and the following year it goes to 3 whole-time equivalents. So that limit of the number of people within this role that you can have, that was absolutely, I don't know about for your network, for us, it was a massive negative. We were planning on going full out and going for 4 this year as part of our original plan. And, having to go from 4 to 1 to cover 7 practices, how we use that role has massively changed as a result of it.
Yeah, I think that's also difficult for the mental health practitioners themselves, because I think these roles work well when they're part of a team working within the local community and not just an individual person. I think that can often be quite overwhelming. Although I suppose being part funded and partly embedded within the organisation providing secondary care mental health services for the area will mean that it might be easier for the primary care networks to access and put in place the necessary supervision and training for those people. So I think that's potentially a plus, as well as enabling them to at least work as part of a wider team within that organisation. So I think there are some positives there. And also, I think there's a lot of potential to potentially improve that interface between primary and secondary care. They'll sit and bridge primary and secondary care, and again, that's a lot on their shoulders to bridge that gap. But if they're used well by primary care networks and by their mental health trusts, then I think there's an opportunity to sort of redefine that interface. And that's something I'm really interested in exploring as these roles are designed. I suppose the final point is we're always worried about the hazard of roles being used to do work that is already commissioned within other services. So we wouldn't want them being, because our attention as primary care networks is divided in all sorts of different directions, isn't it? We wouldn't want them, due to lack of our attention or other issues, to be used to deliver something which is already commissioned in secondary care. So I think everybody just needs to be aware of that hazard and make sure it doesn't happen.
True.
So,
and I think one of the interesting things we figured out as we were going through this document was something that was kind of hidden in the wording. And we're not sure if other people are aware of this, so we did want to kind of go a little bit deep into this. But if we go back up to the document, I've forgotten what number it was, Andy. I don't know if you've got it written there.
Yeah, I've got it written down, but I think it was nearby. Hang on, we were on in section 7.
So as we mentioned, one of the things that came out was obviously the limit of the mental health worker role to one whole-time equivalent. However, 7.3 and 7.4, actually 7.34, sorry, do outline that potentially, and if we've read this right, you can also go out additionally and get a child and young person's mental health worker in addition to the adult mental health worker. So potentially, if you've got an area with significant challenges in mental health issues, deprivation, that kind of stuff, you can still have 2, is our understanding, for this financial year.
I think that's how it reads. That's probably something to get some clarity from NHS England on, isn't it?
So that's definitely one of the questions we're going to be asking them, and hopefully we'll get some clarity on that, and we'll stick it in the chat for a response, and we'll probably update you on EGP learning as well afterwards. But that was an interesting one because I wasn't aware of that.
No, we just picked that going through the document, and I think there's a lot of potential for both of these roles, and definitely the child and young person mental health worker. I think that would be a great role in our primary care network, definitely. So let's make sure we're still on track with our location within the document.
Yeah.
So we've had a look at the table. Anything else to say on the table, Gandhi, before we sort of move back to the main document?
No, I mean, the table outlines the various different roles and that kind of stuff, and potentially the finance and the funding. I guess one of the things we haven't seen is any significant uplifts in terms of the reimbursement for the roles. And still, unfortunately, we haven't seen any support for what do you do when those individuals hit the maximum reimbursement levels. How is that going to be funded? So, for example, we've got things like the pharmacists, what was it, £56,000, 56,829, for example, a maximum reimbursement. But actually, band 8s in particular can easily go over that. So at the moment, obviously, networks are then having to fund that themselves independently. And if we want to retain these members of staff that we're bringing, that's potentially going to be an issue that the networks are going to have to pay more than what the reimbursement allows. So what does that mean in the long term in terms of funding?
I think it's a real issue for the viability of the primary care networks. I mean, I know some primary care networks, in order to obtain clinical pharmacists, because there was a lot of concern about recruiting enough and recruiting the right ones initially, committed to overpay over and above the ARRS amount. And that money is coming from the £1.50 essentially at the moment. But as the complexity of managing all of these increasing numbers of ARRS staff increases, that £1.50 is going to be required to fund the management resource and infrastructure required to actually successfully manage those people. If you're already paying some of that to support wages and may need to pay some of that to support increases in wages going forwards to retain staff, I think that places a really big question mark and burden on the sustainability of the financial sustainability of primary care networks going forward. So I was hoping to see an increase in the £1.50, as well as increases in these wages, and that's something that isn't there. So that's something that concerns me. I think we've highlighted that as a separate point somewhere, but that worries me, and I think that's also something that needs putting to NHS England if they want to build sustainable organisations that can retain staff. Definitely
agree with you. And I guess a couple of extra points to make on that table. So one of the other things that has been a welcome addition, I know particularly for parts of the country, is the London waiting reimbursement amounts as well. So I mean, that doesn't really affect us, me and you over in Nottingham, but obviously for those who work in London, it is a more expensive place of the country. Although interesting to point that places like inner city Manchester, inner city Birmingham are probably fairly similar in terms of the outer London costs. So is there some element of adjustment that needs to be made based on deprivation and other kind of factors? But at the very least, a London waiting is a welcome thing for those working in London. Absolutely.
Yeah, I'd be interested to know from people in London whether it's sufficient or whether it mirrors other London weighting arrangements for other types of roles and jobs that exist within London. So I don't really have the knowledge to comment on that. So I'd be interested to know.
So if you are watching us from London, then feel free to comment. We are going to focus a little bit more on the ARRS calculator in a second, because we've got a really handy website that we want to have a look at you. But we'll get to that when we get to the finance, I think, because rather than jumping back and forth, it's going to be much more helpful when we talk about the finance. So do stick around to see this really quite awesome little tool we've got for you. But as we track down, so the additional things to note about the ARRS roles is this concept of additionality, which I think is really going to start hitting certain networks in this financial year in particular. So the mechanism for working out this whole additionality clause. So just to remind everyone that actually, as part of the whole funding for ARRS roles, you have to continue to increase the number of roles that are available within your network. And that section on additionality does set out everything you need to know about it and what you can do. It does allow for some chopping and changing between some of the clinical roles, like the pharmacists, the physios, the physicians associates, and there's less of a focus on some of the non-direct clinical roles, like the dietitians and the podiatrists and that kind of stuff, because they're not seen, I guess, in an acute-facing way. But definitely not to lose track of that, because you could potentially be penalised and lose access to some of your ARRS funding if you're not focused on the additionality.
Yeah, which I think would be disastrous given the sums required to pay wages. Yeah, I suppose the principle there is it's sort of it's there as protection for NHS England, really, isn't it? Just to ensure that primary care networks and practices aren't shifting people who were otherwise employed by practices to perform a function into the umbrella of PCN ARRS funding, whilst still doing the same or similar role or providing the same or similar service. So it's understandable that that's there, but you just got to be careful that you don't fall foul of those rules. So we talked about the children and young people's mental health role, and that maybe you can have an additional one of those as well as a mental health practitioner. We just identified a deadline here, hadn't we, Gandhi? So workforce planning templates need to be completed for this financial year by 31st of August this year, and through to the end of the initial sort of PCN DES period by October. And I think that's similar to the exercise we did last year, isn't it, as well?
Yes. Which I think confused a lot of people at different times because of the way that it obviously all came out during COVID. And I think the reason why this is really important, so the first deadline of the 31st of August is how much of your ARRS funding are you going to actually use in this financial year? You have to give a clear indication of how you're going to spend it. And the reason for that is if you're not going to be able to spend your full allocation, and not to forget, this year, we are talking significant allocations. I mean, we worked ours out for my network, and I think we've come up to over £800,000 worth of total funding that we've got access to. So, the fact that that may not be used, the 31st of August deadline for this financial year then looks at, if you're not going to use it all, well, then that potential allocated funding that you're not going to use then goes into a slough fund. They've got a particular word for it. I've forgotten what it is. But effectively, it goes to a pot that every network in your local area can then bid for to access even more potential funding. So I think that's the reason why it's there. And it's important to know that it's there. And it's really important, therefore, to really crack on and get your ARRS roles in as quick as possible. Because as we saw with last year, trying to do this in the last 3-4 months meant that many networks have had massive amounts of underspends. And the interesting question is, where's that money going to go?
It's a good question. Just on the flip side of that, Gandhi, and this is just a very quick general comment because that reflects some conversations we've had within our primary care network. Because a lot of these additional roles require a lot of input from practices in terms of supervision and support for these roles, and often they're new roles and they're developmental roles and they're training roles, and some of our practices feel that's quite a big burden, and they'd perhaps be cautioning us to say, well, yeah, it's not free money, but it's money from another source that isn't practice sources to pay for staff, but that doesn't mean that the net cost to practices is 0, and practices, even if they're not putting in something financially, they need to put something in terms of commitment to support the roles. And if they're not roles that are ultimately going to be valued, then it's still not worth bringing them online, if you know what I mean. So just sort of highlighting that some of my practices would say, actually, don't necessarily go mad, because we have to look after these staff if they're recruited. So just finding that balance, but provided you can look after them.
I think, the two parts that aren't really talked about a lot when it comes to the DES is the supervision aspect and it's the estates aspect. Real challenges that we've got in various different places. I know in our particular network, both of those are proving a real challenge. I would estimate that NHS England will probably say that the answer to the supervision part is, well, practices get their network participation payment, which is the £1.76 per registered patient. It's just theirs for engaging with the PCN DES itself. Is that enough? Well, I'll leave that for people to answer themselves. I would argue that it may have been enough for year 1. It doesn't feel like it's enough for year 2, year 3. And in terms of the amount of work that practices are having to do at this point, I wouldn't agree that that's the case. And if it was meant to be the point, then there should have been an uplift with it. But again, that's for people much higher up than us to make those kind of decisions. But we can always ask, can't we?
Yeah, the proof will be in the behaviour of primary care networks and practices. If they do recruit and spend all their money, and if they don't, NHS England need to ask the question, why not? And it might be this issue of support and supervision and value and non-direct.
The other thing to remember is that some of these roles are just not out there. I mean, we've gone out for hiring network managers a couple of times. I know they're not one of the ARRS roles, but trying to find those particular ones. Physicians associates, there's potential significant funding available for those, but actually finding physicians associates is really hard. We've gone out for recruitment twice now and not been able to find enough candidates to fulfill the role. So that's something that I think does need to be factored in, that these roles just are not available in the volumes that potentially networks are needing to satisfy and to maximally use their available ARRS funding.
And before we move on, you've raised estates, and it really is the elephant in the room. And I think you can be very creative with home working and so forth to liberate space, or you can try to be. But in some primary care networks, there just won't be the additional estates to place these people so that they can see patients when they need to. And if you start trying to bring online and rent additional space out of the money available for that, which can only really be from the £1.50, or could you bid to reuse some of your unspent ARRS money? I'm not sure, and I think premises might be listed within the specification of things that you could potentially spend. I think I've seen the word there, but it's really difficult. And actually, NHS England are bringing online a huge number of additional roles and workforce without really considering where they're going to be. There's no consideration really of estates. So that's something that I think we need to ask about as well.
Right. Well, we've talked a lot about the ARRS roles. I think that's probably it for this particular section, if I remember rightly.
I think so. Yeah.
So then we've got the service requirements. So this is the actual stuff you have to do as part of the contract. And the first one that comes up there is the extended hours access contracts. So remember, this is 2 parts. There's the extended hours, which is those hours just outside of your normal routine opening hours. And there's the extended access contract, which was the £6 per patient originally contract that is now being turned over from CCGs to PCNs to administer. This did get delayed. It was meant to happen officially from April this year, so 2 weeks ago. But because of COVID, we gather this all got delayed and is now been pushed back till September 21, partly, but formally till April 2022, unless you're able to, which is where the September 21 deadline comes into play. You've had a bit more awareness of this, Andy, so do you want to talk us through it?
The section in general. So, well, the first thing to say is what isn't there. So in the original network specification that everybody was a bit aghast at in January last year, there were 4 additional service requirements, and I think there was the potential that I think it was said that those would come in this year, so they're on hold until at least October this year and possibly beyond. And those areas were inequalities or tackling inequalities, cardiovascular disease diagnosis and prevention. There was something around personalized care and personalized care plans, and around anticipatory care and end of life care. And those are not being imposed yet, I think normally because of the COVID pandemic and vaccination drive, which are obviously ongoing at this point in time. Just moving through with, so this is the section talking about extended access and extended hours. We were just reminding people that the requirement for extended access is 30 minutes per 1,000 patients per week. So for a typical 50,000 patient primary care network, that's about 25 hours a week, occurring outside normal opening hours. So that's interesting. I mean, in Nottingham, it's currently provided by a federation, isn't it, Gandhi? Via something called GP Plus, and I know they're busy talking to primary care networks in the area, working out how they want to handle this transfer of responsibility and funding stream behind extended access, and whether primary care networks will be wanting to take that on board themselves or continue to subcontract in the way that they do now, but possibly with a more local element to that service. So that's how things are evolving within Nottingham, and I know this is something that'll look really different in different parts of the country. So 8.1 is all about extended access and hours.
And then it goes to some of the other nuts and bolts. So it talks about structured medication reviews. So this has been part of the contract from last year as well. I think one of the interesting parts, so as far as we can tell, there's been an addition to this. It's pretty much the same as what it was, but what is quite helpful is that it clarifies the type of patients that you should be focusing on for your structured medication reviews. And in particular, the thing we seem to think is an addition is the using more for potential addictive medications like opiates, benzodiazepines, and the gabapentinoids, and focusing on supporting those patients with structured medication reviews. And this is going to be, I think, a real interesting part to see how it develops, particularly with NICE reviewing the chronic pain guidelines. They're in the process, and there seems to be massive direction that medication should not be part of chronic pain management. And obviously we know that there are many patients out there that are taking quite significant and quite addictive medications for chronic pain. This is going to be a real interesting point, I think, in about a year or two's time as to how this is managed within networks. So yeah, interesting is the best word I can come up with for this one.
Yeah, I think this is a real challenge for clinical pharmacists as well. We've had discussions in our primary care network about how to tackle this this issue, and I think what is probably guaranteed not to work is that somebody unfamiliar with the patient, who's an expert in medications but not necessarily worked in direct clinical practice and disease management for very long, having a sort of out of the blue appointment with them and telling them that the guidelines have changed and they need to reduce with a view to stopping a lot of these medications. It strikes me that's not the approach. I'd be very, very interested again to know what other people are doing around these issues. I know that even dedicated pain management clinics have difficulty reducing these medications, and in my personal experience often increase them when patients go to those clinics. So it's really tough. I think it's a lot to ask of, I suppose we're just reviewing them, aren't we? But it's a lot to ask of clinical pharmacists alone to reduce these medications and address it appropriately. We're thinking about doing potentially sort of joint clinics with a clinician that knows them well and a medications expert who is the clinical pharmacist to kind of tackle this together potentially. But be interested to know what has worked out there. Sorry, a bit of a segue, Gandhi. I just think that's a tough.
No, like I said, it's going to be an interesting and complex area, I think, for many practices to deal with because of the type of medications we're talking about, but B, also the implications and the other options that are available. Because unfortunately, as you mentioned, chronic pain services are probably not a really well developed service in majority of areas, and it shows by the kind of treatment patients unfortunately experience as a result of it. I mean, it does also specify a couple of other things in that part. Absolutely, one thing that needs to be tight for, I think, many places and make sure they've got it right is the coding of the structured medication reviews, because these are something that you will be evaluated against, and make sure you've got the right codes in your GPIT systems. and the amount that you deliver is still based on the capacity of your clinical pharmacist workforce that you've got. So there's no specific number like there was originally when you go back to the DES requirements a couple of years ago. This is still just based on your capacity that you've got. So nice and well structured. This is one of the areas we'll be going in more detail of in our upcoming talks. So don't worry if you want to know more about it. We will cover that for you shortly. Similar to the next section, which if I remember rightly is LD care enhanced health and care homes.
Yes.
Which hopefully most practices are okay with doing at this point. I mean, obviously this got rushed through, last year when COVID hit massively, and the weekly reviews and that kind of stuff. Again, I don't think there's much to focus on, but there are a couple of points, aren't there, Andy?
Well, so I don't think this is something that's changed very much. So I think it's just about PCNs making sure that they're continuing to embed good practice, I guess, and continuing to either deliver or work quickly towards delivering the requirements of the DES. And there's two main, going over well-trodden territory, I think, but the two main elements of this are the weekly home round or check-in with a lead clinician for each care home that has a way of linking into or providing an MDT approach, and then the requirements of an MDT review of new arrivals and discharges to care homes within a 7-day timescale of being there, essentially, and that links in with a comprehensive community geriatric assessment or that sort of approach, or the involvement of a community geriatrician service. So those are the main things. And then also I just highlighted something that I think we need to work on is about this learning opportunities along with the care homes, which and linking the care homes into training opportunities. I think that's happening sort of organically within a lot of the home rounds, in terms of we're finding where care needs are and signposting them, particularly around respect forms, for example, in our area, and supporting staff within care homes to start that procedure themselves. So I think that's happening, but I just sort of highlighted that partly for my own purposes as something to focus on.
I think it's interesting to see how people expand into this as well, Andy, because I think there's loads of opportunities for things like tech to have a massive benefit for it. So we've gone out and purchased iPads for our care homes as part of our drive to try and support the practices, because we had several care homes saying, well, they can't do video consultations because they don't have any devices. So to try and help with that and to deal with some of the IG concerns that I think some care homes had, we just went out and purchased devices so that they can engage with us. I know other places have looked at getting actual telemedicine equipment into the care homes themselves to help support some elements of ward round reviews and that kind of thing. Absolutely a massive fan of the Echo Duo to help with that. I know many of IGP learners have probably seen my reviews of that. So there's some really interesting tech out there to help you do a lot of this work, but mindful of the fact that it is also focusing on that weekly ward round review and that MDT approach, particularly with the community geriatricians, which we've had recent contact with over the past week or so as well, haven't we? So.
Yeah, so it's a really interesting area. I think it largely depends on the willingness of the care home to participate as well, because at one end of the spectrum I was doing a Microsoft Teams webcam based really effective ward rounds with one care home, and then we have other care homes which still sort of struggle to get a list of patient tours in advance that they want to discuss. So it's a bit hit and miss from a care home perspective as well, but I suppose at least if we are doing our bit and then supporting care homes to engage, I guess that's what we can
absolutely
do. So early cancer diagnosis, so this was an area that I think many of us actually were making reasonably good progress at the beginning of last year, and then had PCN-wide meetings to look at referral patterns and start practice on the path of completing audits of their cancer referrals and outcomes. And we had talks from organisations that, third space charitable organisations that operate within the cancer space within our area. And then the requirements to complete that work were postponed, and it was largely paused. But it's back. Well, maybe, yeah. But it's back anyway. So has much changed from last year, do you think, Gandhi, here?
No, I think the majority of it is there. I think there's absolutely needs to be a focus on this, because we know that with COVID happening, there's potentially this concern about a cancer time bomb waiting to go off in terms of people presenting late in particular, because we know things like screening are down. We know that, Lung cancer diagnoses are down, various other kind of things in terms of presentations that have changed. So I think, having a focus on cancer is not necessarily a bad thing at all. I think how practices do it, be interesting to see how this progresses with that massive change of COVID and the impact it's had on the services and perceptions of people. But yeah, it's a nice, tidy little section to have a look at. We will be covering this in more detail, and actually, particularly this part, there's some really excellent resources in the NHS England specification for the early cancer diagnosis part. So I think I'm covering that one, aren't I, Andy? So we'll go through that in a lot more detail. It's not that big a document as well. It's only 8 pages, which compared to some of the other ones that we've got around, it is not that bad, but it's very resource dense, which is helpful in some way. So we'll be going through that shortly, and be able to go through that with you in due time.
Yeah, I suppose in brief, you have to review patterns of referrals and treatment.
Mm-hmm.
There's an element of trying to move the needle in terms of participation in screening programs.
Mm-hmm.
And then there's a communication piece about getting practices and clinicians within practices talking to one another and doing some peer review and peer learning exercises. Those are the 3 main strands to that section.
So just before we go on to the next section, just a couple of quick points. So we've had some comments, and so thank you first of all. First to Victoria Hoyle, who's mentioned about she was a CD and she's originally resigned after a year, and that was mirrored in their areas. So we asked about people where they've noticed change in their clinical directors. So definitely a nice comment there. And secondly, I'm not sure if I want to show this one because it may lead to a change of our viewers, but to Debbie Lynn, she's asking, will this be available to view later? Because she's finding it really helpful, which is really nice. Thank you for that. Yes, it will be available later. It's the same link, so you can catch it on the replay. But feel free to stick around if you're able to, because we love your questions and your participations. And we're definitely getting to the point where I'm sure you're going to be asking us questions shortly in more detail when we get to the finance part. But if you do have to go, don't worry. It's available. You can access it later. Good. Shall we crack on though, Andy?
Yeah, it was lovely to get comments. And then the final service area was social prescribing. Just 2 sections, very short, and I don't think anything's really changed there,
No.
to be honest. Although obviously one of the IFF targets relates to social prescribing uptake.
Yes. And we'll come to that in due course, but definitely that's the part where you need to pay a little bit of attention to social link workers and things.
Yeah. The next section discusses contract management. And again, I think this is probably a section that will be referred to where things go wrong or are being questioned, as about how the commissioners will ensure that the service is being delivered. So financial entitlements is number 10. I've got a little note here to skip straight to the table. So let's do that.
So the table outlines the various different payments that the networks are entitled to, and that's both from a practice perspective as well as from the network perspective. So it mentions various different parts. There's the clinical director payment, which is paid as a whole-time equivalent. So it's 0.25 of a whole-time equivalent, although for the first 3 months, there's an additional top-up being given due to the COVID vaccination side of things. And I've forgotten the amount it is pence per patient, if I'm being honest.
Is it still 0.75 whole-time equivalent?
There it is 0.736 pence per patient. Yeah. So, and that's for the clinical clinical director administration kind of fee to support the networks. Then we've also got the core funding, which is £1.50 per registered patient for the network. I guess this is one that we kind of hoped at some point we may see an uplift in that, but it doesn't look like that's happened this financial year at the very least. Yeah. Were we being too optimistic?
Yeah, we discussed this point before, didn't we? We need to ask NHS England about that, because I think by the time you get to years 3, 4, and 5, I think that sum isn't going to be sufficient to run the organisation. So I think we'll have to see some movement in that figure.
Mm-hmm. The extended, the extended hours access payments, that confirms the payments of the original extended hours that was part put into the GMS funding, but also then the additional amount that comes to the network to provide the 30 minutes per 1,000 patients that practice have been doing since the inception of the DES itself. And then the new one, obviously, that came in part way through last year was the care home payment. So the £120 per registered bed, and it outlines what type of payment care home qualifications are for that. And that's useful to know, because that hopefully helps to contribute towards the care home work that practice are now having to do. Although I still don't think it's equivocal to the amount of work it actually generates personally, but that's my view.
Is this the point at which we were going to go to the Ready Reckoner calculator, Gandhi?
We are, yeah. So to help with this, and there's a massive shout out to the team at GP Rota who have come up with this. And if you haven't seen this website, I would highly recommend that you go and have a look at it, because I found it really useful. And more importantly, it's stopped me having to go off and make this myself, which was really nice. It's nice when somebody's done this. But what I would suggest having a look at is, if you go to, we'll put the website down below, gprota.net, but there's a particular part of it, and it's basically got a Ready Reckoner page, and it tracks out your PCN. So at the moment we've got Andy's selected, which is Bulwell and Top Valley, but you can put in.
Let's go to yours. Let's go to Nottingham East and give it a change. Okay.
And then it basically finds the registered practice based off the information that NHS England have. It then puts in the practice populations. It gives you your total population based on your registered list size. And I'm pretty sure that's correct, that number, in terms of the way. Yep, 698. Yep, that's correct. And then you can even stick in the number of registered beds that you've got for care homes. So that'll add up that amount. And then that gives
roughly,
you...
What are you, about 300?
I think it's 220 something, was it? We're very similar to yourself. I must admit, I've forgotten the number. Yeah.
Oh, we're like 400, 500. We're late.
Okay. Maybe, yeah, I must be getting it wrong then. But yeah, and then you've got the amount that it gives you in terms of your funding, which is really nice. It tells you in breakdown how much funding you're actually equivocal to. But then the really cool part is the ARRS calculator. And this is just an absolute godsend, in my view. So you can work out how much you're currently spending, how much the potential roles can work, and just by sticking the numbers in, you can get that changeover in terms of what may work and what won't work and that kind of stuff. And it then tells you how much ARRS funding you've got left over to use as well.
How much you're spending and how much is left. So fantastic. Yeah, it's great, isn't it?
Yeah, no, I really like this. I kind of question why NHS England themselves have not gone off and created this. I think they've now done it this year to some degree with an Excel sheet, which is nice, but it's not user-friendly, in my view. This is just so nice. It's everything in one web page. You can adjust it instantly, quickly. Massive shout out to gprota.net team. Really like this resource, and thank you for them to creating it. So I'm going to stick this in our officers kind of group and basically say that this is what we work off in terms of figuring out our budgeting for the next year and stuff.
Looks fantastic. Good. So yes, that was the funding table. So yeah, static, I think, was the only comment. Although I suppose we're in a world where we're going to be facing a lot of austerity, aren't we? I don't know. Maybe I'm making the government's argument for them. No, healthcare should be valued and we should pay for it. And in an environment where there have been recommendations to increases to staff pay, not increasing these payments for things where staff is the ultimate cost, makes things more challenging, I think.
Well, for example, I don't think there's been an increase in terms of the DDRB recommendations either, have there? So, there is that element of, there's been talk about pay uplifts for NHS workers and stuff, but that hasn't translocated across, as far as I can see, to the reimbursement for the role. So, yeah.
Workforce, we had some notes here, but I think we've covered these already, haven't we, really, in terms of the London regional weighting and 50% funding for mental health practitioners. So those come up again. We're just highlighting, just make sure so in Nottingham, we have an arrangement with social prescribers where we purchase that as almost as a service, really, from our federation. And there's the possibility of claiming some additional reimbursement if that's the mechanism by which you employ social prescribers, just social prescribers, not other services or other members of staff. So just make sure that you're claiming that, if not, and it describes how to make that claim. And then I think we're sort of coming towards the end, really, because we're back at a table that we've seen before about the reimbursement for the ARRS staff. Investment Impact Fund. Yes, this is another big area. And I must admit, I think I'm guilty of taking my eye off the ball, as a lot of people are really sort of mid-COVID to to how we were doing in terms of hitting these targets. So yeah, do you want to just briefly talk us through the concept, the quaff for PCNs really, but
yeah, that's probably the easiest way of describing it. It is quaff for PCNs. There's various different criteria that you need to achieve. There's 225 points in this particular financial year, of which each point counts as £200. And then this is a question we are going to ask NHS England, because I must admit it is really confusing. And if there's somebody that's watching this that understands this a lot better than myself and Andy do, please tell us where we're going wrong with this. But there's a concept about a prevalence adjustment that comes into play. And the reason why I think this is confusing, I've heard some people talk about the fact that this can significantly impact the amount of funding that you therefore are eligible for. So if you go on the basis of 225 points at £200 per point, that's £45,000 available to each network, irrespective of its size. But then I've heard some people talking about the fact that their IIF funds are potentially £100,000 based off the prevalence adjustments that come into play. And I just can't work it out, to be honest. It gets confusing, and yeah. I don't
say that again, Gandhi. So people are getting more than £45,000.
Well, they're thinking they might do because of the prevalence adjustments, and this is the part I really, I mean, we spent a good 20 minutes trying to figure this part out, and we struggled, didn't we, Andy, to make head and tails out of this.
Yeah, we probably need to give it to someone doing like GCSE maths, probably, because it just looks like normal arithmetic, or or algebra. Sorry, but it was feeling complicated and couldn't quite get to the bottom of it.
But I think if we go down to the table, it will probably be a bit more clear in terms of some of the aspects. So just like with QOF, there are various different things that you need to do. And if you do them, you get the payments. There's two different types of IIF statements. So there's what's called standard ones and binary ones. There's only one binary one that you need to be aware of, and it is the most important one for now that you need to be aware of. And that's it's the access one. So this is the standardization of GP appointments. There is a deadline of the 30th of June that you have to have aligned all of your appointments in your appointment book to the 26 different rota appointment types. They're in the GP standardization document, and we'll be covering that one in more detail. So don't worry about not having read it or gone through it in detail at this point. That will be coming up shortly. I've been looking at that for the past week or so. So hopefully that episode will be out in the next few days. But basically it's aligning what your appointment book looks like compared to the 26 different appointment types. And you have to do that by the end of June. If you do that for all your practices, then you have got the payment. And that is 27 points. So that's what, £4,000. All right.
Probably
4,000 something odd pounds for your network. And then basically you then also have to do the subsequent work as well that comes with it by August, which is the second deadline in terms of matching up the workload. And I think this is a really important one, because this one potentially does help us understand the workload that general practice is facing, because at the moment they're going off, the centre is going off data that I don't think is accurate. Many people feel is not accurate, and the only way to make it accurate is to report it correctly. And by doing the standardization of appointments, that'll help to make it look more sensible. But this is a piece of work that practices and networks are going to have to do together. And like I said, this is the one with the earliest deadline. So yeah, absolutely, I would recommend, if networks are not focusing on this, start doing it now, because you've only got a couple of months or so left till the first deadline hits.
Gandhi, do you welcome the inclusion of this sort of process data monitoring measure within the PCN DES? Is this about developing communities, and is it about population health, and is it about collaborative working? I'm just wondering, I think if more of this sort of stuff were to continue to appear, it feels like PCNs are being asked to be the data police and do a bit of work that perhaps ordinarily or previously might have been done by a different part of the NHS here. So
the interesting part, this is part of the GP contract. So this is not necessarily part of the DES contract. This is actually part of the GP contract, but the payment for this is just an incentive for practices to get on and do it quicker. So
okay, so it's money for something that we're going to be required to do anyway. So maybe I shouldn't complain. I suppose it's just about who they're getting to to police it and do the work, and whether it's the
I think
clinical
there is
directors
absolutely
who
that
should
question
be
about
shaking
how
the
that.
stick.
Yeah, I think there's absolutely that question then of how that data is going to be used, and how it's going to be shared. But actually, if it works the way that I think it could work, this potentially gives us at least a unified landing point to know what workload currently is in general practice, which is one of the things that we will talk about, and we know it has been absolutely chaotic. But actually, this is a way of potentially quantifying it, and more importantly, that being comparable, for example, for a practice in Nottingham versus a practice in London, and having a bit more depth of data to help understand that. Don't get me wrong, it's going to annoy a lot of people having to do this work, but actually it's probably sensible work that for the longer term means that we have more accurate information to know where we can move forward with various different parts from. So I do welcome it. It's nice that there's a payment for it. I appreciate it's going to make some people think it's definitely not enough, and other people say, well, it's not too bad. It does depend on how your practice runs. It's going to make a massive change to particularly that second part of it. The first part, to be honest, is not really that difficult. My practice did it in half a day, but the second part is the more challenging prospect of it.
I agree with everything you're saying. I just wonder if clinical directors have enough to do already, rather than police.
Well, to be honest, this is the practices are going to have to do it, because the clinical directors can't go off and do this for them, because it's definitely how things work in your practice. But I do think the clinical directors need to have practice eyeballs on this, because it is the first deadline when it comes to IF funds.
Absolutely. I'm being Mr. Complaining Pants. So, and then the other indicators are the non-binary proportional indicators. So some of course binary as well, isn't it? But a bit more like we're used to with QOF in terms of achieving a specified outcome or activity within a range that we get paid for in a sliding and increasing fashion according to the formulas that we were struggling a little bit before. But the general principle is payments are zero up until a certain threshold is reached, and then you get a proportional increase of the payments as you work towards achieving the maximum payment, and then beyond that you have achieved the maximum. We're all familiar with that from QOF. And the first three markers are around vaccination uptakes. So marshalling PCN resources to coordinate and support vaccination drives.
Of which the cohort for the 18 to 64s is the biggest one. So that's absolutely one that you should be focusing on, because that's 88 out of the 200 points. So, being aware that that's a key part that you need to have your eye on the ball. I'm a bit confused about the 2 to 3 year olds one, because we don't tend to do as much of that in general practice. That's obviously delivered through the schools process. So how much control we've got over that, I think, is an interesting part. That one confused me a little bit.
Yeah, absolutely. And then there's learning disability health checks.
Yep. So
that's a piece of work that needs doing. And then there's the social prescribing indicator as well. The percentage of the population reached by social prescribers. I'm right. I've got that right, haven't I?
You have, and it's not a small amount. I mean, I worked out for our network that it equivocally works out to about 2 referrals a day, which I don't think we are doing anywhere near that, to be honest. We're probably doing 2 a week. So again, if you want to try and achieve that particular part of the IF fund, I think if you've got well-established social link workers that are functioning very well in practice, it probably work quite effectively. But I mean, my network's relatively large-ish, coming up to 70,000 patients, but 2 a week is a significant amount of referrals to be doing.
Yeah, so for 50,000 practice, it's to hit the lower of the threshold, 0.8, it's 400 a year, and that equates
that's what, 1.5 a day.
Yeah, so it's about 7 or 8 a week. So if you call it 8 a week and you got 5 working days, 1.6. So 1 to 2 referrals a day. So I think you're about on the money there, Gandhi, with your calculations, which is achievable, but it's quite a lot of work for your social prescribers to process that number of referrals, given they're often quite complicated cases. So
yeah,
interesting.
But that's the IIF fund. So we are going to do another video that goes into this in a little bit more detail, and talking about, the various different aspects and potential ways you can try and achieve those criteria. And in short, that's the document. So yeah, it's big, it's massive, but hopefully we've summarized it a little bit more for you and trimmed it down, so that it's a bit more manageable. There are definitely points to focus on, and particularly the additional roles. If you want to have a look at more details about the way that NHS England particularly envisages how you can use those roles, especially the difference between a trainee nurse practitioner and I forgot the other, nurse associate or whatever it was.
I think that's right. Yeah.
Yeah.
So you're talking about the role specifications. So there's actually a good 1/4 of the document is taken up by Annex B, which describes the minimum role specifications. It's really helpful when you're designing your recruitment process and working out how to use the roles, to refer to the definitions there. And they are there for the new roles as well, like the mental health prescribers and so forth. So with a good look in that section.
So we've had a couple more questions come in, and I've just asked everybody else if they do want to ask any more questions, feel free to do so. So in terms of doing that, we've had a question from Samantha Bell. So she's asking, where does the funding come from, the equipment, instruments, etc., for FCPs like physios, podiatrists, and that kind of stuff? I'm going to, well, yeah, I'm going to say it's going to be the £1.50, isn't it? There's not really a pot of funding. I mean, there have been some underspends from previous years that have been aligned to use, like you said, Andy, for things like estates and equipments and that kind of thing. But majority for the ongoing is going to be the £1.50, or the funds that you make from the IIF fund. So it's not a small pot to minimise on. The IIF fund is potentially a useful resource for networks to utilise. But yeah, that doesn't come out of the ARRS roles. It comes out of basically the other funds that you can get access.
Yeah, there's sometimes money that comes through for sort of organizational development and increasing the capability of the primary care network, and sometimes you can shoehorn some of these needs into justification for spending those funds as well. So that's another way to fund those sorts of requirements.
So EGP learners, we've covered quite a lot of stuff for you. Hopefully you found that really useful and informative. As we said before, a lot more of the in-depth guides in terms of the various different aspects. We talked about obviously the standardization of GP appointments. We talked about the structured medication reviews, the IF fund, the enhanced health and care homes, and I'm forgetting one, the early cancer diagnosis and stuff. We will be going through those in more detail, myself and Andy, taking it in turns in picking one of each and things, and going to that for a short kind of summary so we can go through the additional and more in-depth guidance that we have for those for you. So definitely check out EGP Learning over the next couple of weeks where we will have that information. Additionally, if you are watching us live, join us on Wednesday. So I'm going to be going through a massive System 1 update with the team from System 1 that talks about particularly their new communication annex, which I know many of you have been looking at some of the videos we published this week about. But they've got some really cool features on there that if you're a System 1 user, absolutely you want to be checking out. So we're going live again, 12:30 on Wednesday, the 21st of April. You'll be able to see some of that. Myself and Andy are going to be a little bit busy next week because we're doing our GP5T conference. So if you are joining us, yay, you get to have us for the Saturday morning. And if you are interested in joining that, we'll put the links down below again in terms of you being able to register for our training trainers to train trainees conference that we are doing. And as always, I guess, Andy, here at EGP Learning, we're here to help save you and your patients time by taking enhancing primary care and learning. We'll catch you in the next episode, won't we?